for your presence of you here. I want to thank to the bioprogressive member for this kind of invitation. It is a pleasure and an honor to me to share this moment with you. And also the privilege to Dr. Gugino as moderator. Thank you, Dr. Gugino. I'm going to talk about several reasons of early treatment. Early treatment that I'm usually do in my offices, and I'm trying to deal with some theory and practical concepts. Before starting, I want to share with you some pictures from our country. This is our institution in Argentina, the bigger one in orthodontics, an 80-year-old institution, Argentina Society of Orthodontics. We have two buildings, one recycled, where the clinical and attendance activities are carried out, and the other building in the heart of the Buenos Aires city here is when the institutional activities are carried out. We have this is the reception area in the new building, and here we have our clinics. We have 3 clinics, 2 with one another like this with 10 dental seats, and another in the top of the building with 18 seats for attending patients. Below is the library, and here our university, Argentina Catholic University, in a beautiful place in Buenos Aires and Puerto Madero, beside the La Plata River, area full of restaurants like the Pier 39 in California and San Francisco, something like that. And here the first day of our current students, they are 18, 17 women and 1 male. Okay, I'm going to read I have some light, excuse me. I prefer to read because my memory, I want to not forget anything, and my memory is like my English, so I prefer to read. Okay. At present, contemporary orthodontics offers endless possibilities of treatments by means of different devices and techniques, and there is a wide variety of therapeutic aims, like rapid distalizer appliances in this 42, 43 years male patient, initial and final, treatment referred to TMJ disorders, like this in a patient with 33 years, initial and final. Also, treatment with lingual, the use of touch of microimplants in other patients, as this case, with these final results, initial and final. Treatment with lingual orthodontics, very much in demand nowadays in Argentina. We founded the Argentina Lingual Orthodontic Society in 2005, and I was one of the founders and the first president. And here my partner, Dr. Marco Jorge Rubio, is the current president. This is a female patient with lingual orthodontics, sorry, and 35 year-old female patient, initial and final. And also we can do orthodontics with orthodontic surgery with good results like this. This is the initial pictures, dolphin diagnosis and prognosis, and the final result with the bimaxillary surgery with cheek alloplastic graft. This I will need some light to read the maybe. If not, I'm going to. Okay, maybe at the top. No problem. No problem. All this treatment. All the treatment pursuing for three basic goals: functional occlusion, aesthetics and facial harmony, and post-treatment stability. I think our concept for adult patient treatment is quite logical, and matters referred to orthodontic surgery are certainly welcome and really valuable. However, let me tell you that you have a gap that goes from 5 to 15 years old approximately of growing patient, where we have a lot to prevent, intercept, reeducate, and treat. All the same of this aspect I have mentioned at the beginning: functional occlusion, aesthetic and facial harmony, and post-treatment stability. So I'm going to speak about early treatment, which is a way to improve the final aesthetics. We can say a lot about early treatment, but this is just a presentation of a few positive aspects. I would like to mention technical possibilities, psychosocial possibilities, and biological possibilities. As regards technical possibilities, you should mention the simplicity of the appliances, as the treatment will be developed during primary and mixed dentition, and why any kind of fixed appliances consist only of 2 bands or tubes and 4 brackets with very simple arches, and the use of internal arches of expansion, which reflects the aspect of easy handling. Among the psychosocial characteristics, we can mention the treatment of severe class 2 and 3 with all the inconvenience this malocclusion will surely bring in the future, for example, teasing from partners, and also the traumatic problems concerning the fracture or loss of upper incisor and functional problems associated with class 2. And as regards class 3, the goal is trying to prevent or intercept disorders which will develop due to this kind of sagittal anomaly. Psychologists mention the latency period, a period which shouldn't be missed at this stage, which covers from 6 to 10, 11 or approximately. And it is characterized by the patient cooperative behavior and the desire to please the adults that surround him. As I have said before, this is a period that should not be missed. Consequently, we should try to avoid the adolescent stage, a period characterized by rejection and rebelliousness. Last but not least, we have to mention the biological characteristics in which we have to respect the normal development of the functional matrix. When we refer to functional matrix, we are talking about proper breathing and swallowing. Any upper pharyngeal obstruction will develop oral breathing, lower tongue position, upright head position, which will develop in maxillar narrowness, distal mandible position, dysfunctional swallowing, and labial incompetence. We must not let this happen, and we should lead to normal behavior of the functional matrix. To sum up, any habit must be treated as early as possible. Finally, we must not forget the growing period which every orthodontist mentioned but nobody profits from except when we treat early. Therefore, any tridimensional skeletal change should be carried out on this stage of the early treatment. In this stage, we can identify 3 phases. Preventive, a phase that ranges from 4 to 7, interceptive to 8 to 11. For me, the most important because it is characterized by mixed dentition in which the arch length will be treated. And finally, the corrective with growth, which range from 11 to 14 and takes the beginning of the permanent dentition. According to the type of the malocclusion, the age of the patient, and the chronology of the eruption will determine the possibility of 1 or 2 phase treatment. 1 phase treatment may last 6, 9, or 12 months, and perhaps it may be the only one needed. Or a second stage may be necessary during the permanent dentition period. Personally, in certain cases, I'm used to getting 1 treatment phase of 2 or 3 years in agreement with my VTO determination. Of course, this requires the parents' approval. This happens when I'm absolutely certain that will be the only possible stage which will take place during the middle or final mixed dentition period, sometimes covering the beginning of the permanent dentition. Either following a 1 or 2 phases treatment, we have to bear in mind a designer's progression. That is to say, we are talking about early treatment, and is to say we are talking about bioprogressive treatment. In early treatment, and according to the bioprogressive principles, we will talk about the 3 orders throughout treatment. So here, the basic appliances for a tridimensional therapeutic response. So, in early treatment, we should be know how to diagnose ectopic eruptions, crossbites, middle diastema, agenesis, impacted teeth, supranumerary teeth, malformation, and habits. So, after these basic concepts, we can start talking about the 7 reasons for early treatment. And I have selected to present to you today sagittal orthopedic treatments, functional matrix reordering, orthopedic orthodontic transversal corrections, habits eradication, early vertical unlocking, lower arch space control, and early establishment of facial aesthetics. So, we are going to talk about sagittal orthopedic treatment and functional matrix reorder. The question is, distillation, yes or not? It will depend on where the problem is. Watching this picture from the Rocosi Petrovic engraving book, here we will need a forward mandibular treatment, and here in class 2 first division with upper maxilla defect in meso-umbrachiofacial growing patient, neighboring to the growth part, the therapeutic response will be the cervical headgear. Using the cervical headgear, we can say that we will obtain an orthodontic response consisting of a molar distal movement and a molar rotation, and an orthopedic anchoer. Perhaps the most important reason why we have to think about this specific therapeutic tool, which is over 150-year-old. I didn't find any other appliances with this response, this therapeutic orthopedic response, like you will see. When we talk about orthopedic response, we refer to a brow stopping, upon reduction, maxillary expansion, mandible repositioning, change in the palatal plane, and something else. When we say mandible repositioning, it's referred to an occlusal intermediate position when the first upper molar is going to class 1 position and the mandible looks for a stable position through a forward one. Therefore, we are talking about three-dimensional orthopedic changes. So we see that something will happen. Something like this initial, intermediate, and final X-ray records refer to a class 2 first division mesofacial growing patient where you can see the sagittal occlusal changes in the molar relationship from class 2 to class 1. Excuse me. And the incisal guide occlusal plane and aesthetics change with the use of cervical headgear and utility arches. Let me show this 9 and 7-month-old male patient who presented a slight convex profile and a class 2 in a mixed dentition with increase of overjet and overbite. His X-ray records, head films, and tracing showing an upper maxilla defect and exceeded E-plane. 10 months with cervical headgear and this aesthetic change and E-plane improvement and in a class 1 occlusion. Also, due to a little posterior mandibular rotation, there was an overbite improvement and a lot of space with a little distal molar rotation and a new maxilla shape. 2 months later, an intermediate X-ray record showing the orthopedic, orthodontic, and aesthetic change. My apologies about this picture, but this is the only witness referred to this upper utility arch for leveling, closed space, and a slight intrusion. It was taken long ago with the first digital cameras. Final pictures, initial, the final, record the pictures, initial and final, initial and final, initial and final, initial and final. Let me stop here. I use 2 bands at the first upper molars and after the headgear stage, 4 brackets and utility, upper utility arch. Nothing else. So what happened? What was this initial square maxilla shape transformed in this ovoid parables 1? I only prescribed an 8-hour use of this outdated appliance with upper molars expansion and posterior rotation. Nothing else. I didn't use any devices on the deciduous teeth. So what happened? It was a secondary expansion of the upper maxilla and compensatory expansion of the lower arch due to a functional matrix reorder. Let me show another growing patient, an 8 years and 1 month old female patient who presented who showed at the moment of the picture different habits and gestures. She had a dysfunctional swallowing due to a significant increase of the overjet and overbite. She was a class 2 first division with narrow upper and lower crowding arches. Due to an occlusion interference, she was even a more severe class 2. Here, her X-ray records and tracing showing skeletal and dentoalveolar class 2 first division with maxilla defect where the facial angle axis was not too favorable. So, I decided to use a cervical headgear with an orthopedic force about 400 grams with the outer arms direct to the tragus to enhance the orthopedic response. In this case, having in mind some unfavorable cephalometric parameters like the facial angle axis, I decided to use together the cervical headgear and a lower utility arch, trying to avoid the posterior mandibular rotation. Perform a utility arch looking for the alignment, leveling, and intrusion, and a first molar expansion and rotation looking for a class 1 and a mandibular repositioning. Once again, the changes. And here the upper anterior alignment with another preformer utility arch. An improvement of bilabial contact after the debonding with the upper central incisor showing a barrel shape. Lower lingual arch as temporary lower retention and an upper plate. And this new aesthetics with a very good bilabial contact and her X-ray final records and the comparison. Initial show an increased speaker intermediate with the first upper molar coming to class 1 and the last one with a good class 1 and good occlusal plane. And let me show the superimposition where it seems that the mandible doesn't go back. Okay. We can see dental changes, a fair upper molar that didn't follow the forward growth, some incisor changes, an orthopedic change with a point reduction, and non-posterior mandible rotation. But yes, an inverse clockwise rotation, as Robert Ricketts has explained to us with the use of the cervical headgear, both with the utility, lower utility arch. Here, Robert Ricketts, the last visit to Buenos Aires in November 2001, showing the use of the cervical headgear. Initial and final. Initial and final. Initial and final. And once again, what happened? What happened? The inner arms of the headgear worked as a muscle bumper and let the functional matrix neutralize. That's what Font says. So I expanded and rotated the first molar. The utility arches aligned, leveled, and intrude, and also cooperated as lateral bumper. And once again, I didn't put anything in the lateral insection. So it happened a secondary expansion of the upper maxilla and compensatory expansion of the lower arch due to a functional matrix reorbit. Okay, let's now talk about initial and final with a good bilateral contact. Let's talk about orthopedic orthodontic transversal correction and habit eradication. Having already in mind the 3 dimensions, we must point out the importance of the 4 aspect, as it is a distinctive feature of this therapeutic system. It is time that will allow us to carry out 3-dimensional orthopedic changes, growth redirection, functional correction, intercepting habits, etc. we should also point out the relevance of the transverse dimension, frequently forgotten in the orthodontic diagnosis. This should be verified by the cephalometric diagnosis, and for ricket frontal analysis we can take a few measures to obtain a basic guide that will lead us towards the right diagnosis on transverse anomalies. For example, these 6 special parameters. That is why we say upper expansion will be orthopedic and orthodontics. And when we mention lower expansion, I know some kind of controversy might arise from this point of view. However, this refers to compressed dental alveolar processes due to the dysfunction, which must be returned to its normal axial position. All this should be checked before and after with transverse parameters already mentioned. Therefore, when we perform lower expansion, it has to be dental alveolar. So, the therapeutic response in the maxilla would be the use of the quad helix, and the lower arch would be the use of the bihelix. Michel Anglade mentioned in his book Transversal Optimization the quad helix properties like sutural disjunction, dental movement, expansion of contraction of dental alveolar processes, or bilateral molar rotation. And here he shows us a chart highlighting the quad helix qualities as a slow disjunction appliances. Let me present you another first phase clinic case, a 5-year-old female patient born at 8 months of gestation with some general lateness in her development, a growth backward tendency clockwise, and an occlusion with anterior open bite, upper narrowness, and across the lower arch and primary dentition. We all know that when we have this crowd lower arch in primary dentition, we surely would have a problem. So, if you don't treat a crowd lower arch in primary dentition, we will have a severe crowd lower arch in permanent dentition. What? So, the challenge was whether to treat or not. And this is what I did. At this moment, in this presence of this kind of malocclusion, we have to deal with the concept of the tridimensional unlocking of the malocclusion. That it is a starting point toward the functional occlusion. We refer to a mechanical unlocking through the action of the disc basis appliance, but this mechanical unlocking will not be stable if it's not complete with the idea of the functional unlocking, as Dr. Gugino mentioned in the zero-based concepts. We have previously talked about respecting the functional metrics. So, when it is altered or threatened in its proper development, it must be reoriented through this double concept of mechanical and functional unlocking. Therefore, in early treatment and bioabrasives, we support the idea of a widening of the therapeutic range. Not always, but very frequently, the orthodontists have to work together with another specialist, such an ENT, a functional myotherapist, and sometimes a physiotherapist. That is why I refer to an interdisciplinary behavior which confirms the concept of functional and mechanical unlocking. This as regards our job, we believe in a functional criteria with fixed appliances. So, I began with a mechanical unlocking, and the ENT carried out the functional unlocking through the dermatectomy. We can notice again the suspicion change in the posture. Upper over expansion, and in accord with this Layton study of 500 individuals from birth to full growth, we would need at least 6 millimeters of spaces in primary dentition to have the necessary space in the permanent lower arch. But we are in this situation. So we will have a severe problem. Then we need to make a lower expansion looking for spaces. 14 months later, with a young mixed dentition with an apparent better prognosis and the X-ray records, one initial, two after the use of the quadhelix, and the third after the use of the bihelix. The same in the frontal view, before beginning, after the use of the quadhelix, and after the use of the bihelix. Just let me show the tendency beyond the figures themselves. Before the upper expansion, showing these increased measures. So I suppose to expand the lower arch. And after the orthopedic action of the quadhelix, we have a bigger possibilities of lower expansion because the chase point were to outside. So I have a bigger possibility to expand, and the compensation after the expansion through the bihelix action getting closer to some normal parameters. So what I have to tell to stop, okay? At the end of the first stage with an apparent improvement of spaces. And here, 2 years and a half later, we can see the patient waiting for the starting of the second phase with a mixed dentition stage, normal sagittal relationship, improvement in the vertical sense, and an arch length with a moderate growth and real possibilities of successful treatment just together with the highest growth point. I believe that now it is an easy case to take in this final stage. Let me show you the therapeutic response transverse response to a sagittal anomaly and arches with lack of space. A 10-year-old female patient with dental sagittal class 2 and lack of anterior space. The question is, begin or not? The question is, begin or not? I ensure the upper lateral incisor will erupt in a palatal position or in a rotation with future trauma with the anterior lower incisors, resulting sure in an arterial crossbite. So the answer is yes. The answer is yes. And it may be solved with the transverse treatment to a class 2 relationship. Upper over expansion and first molar rotation looking for class 1 relationship. A customized upper utility arch to early middle line establishment. Please have a look to the sagittal relationship, to relationship starting from the transverse mechanic, going from class 2 to class 1. An over expansion, and now a lower expansion with smooth support on the lingual surfaces of the lower incisors to bring a future forward movement. X-ray control, upper and lower over expansion, interoral activation, and upper utility arch aligning and closing spaces. Here the establishment of the occlusal lateral guides in a new class 1 relationship is very important. A little lateral alignment and the end of the transverse with a temporary lingual arch, a good arch shape, alignment and midline. and the final aesthetics. 12 months later, control with a nice smile and with a nice smile line. Initial and final. Initial and final. Let me share another clinic case in a 10-year-old female patient who presented a good growth tendency and a good facial balance. A class 1 with a good maxillar base, but with the habit caused by a dysfunctional swallowing. As a result, she presented an anterior open bite. Someone would say, anterior open bite, avoid whatever expansion treatment. It is wrong. We must intercept the habit. How? With an expansion appliance, a quadrix, with the anterior bridge in a forward position. What for? To inhibit and interfere with the pressure of the habit action. Here with the help of 2 brackets in palatal surfaces of the upper central incisors. The missing bracket, once again, the lateral arm adjustment and the bite is closing. The bite is closing. X-ray records. The bite closed and the occlusion is going better. Alignment with a preformally lower utility arch. Nothing at the upper arch. Nothing at the upper arch except the quadrix. Let the functional metric work and let the bite close. Let the bite close. A square angular blue lower 16 utility arch and 2-second lower molars erupting in a lemmal cross bite. What if you want 2 tubes and put in a 1490 overlap arch with build-ups in the 4th molars? I'm ready. This is intercepted orthodontics. It's really too easy. The tubes will remove and the occlusal force and the functional plane will put them at the right place, as Robert Ricketts said. We are finishing, but the last guest to the party didn't find any room, so a short stay with the upper fixed appliances and this final result.